Son, you are a very good and thoughtful person. Even though you were in pain, you never showed it to us because you did not want us to worry. I am very grateful to HCA for taking care of my son and supporting our family all the way. Don't worry, son. I am in good hands.
Test.
สวัสดีค่ะทุกท่านถ้าพร้อมแล้วกรุณาปิดประตูนิดนึงนะคะพร้อมแล้วกรุณามานั่งข้างหน้าได้เลยค่ะจะได้ช่วยกันดูชัดๆนะคะเรามีสิ่งที่น่าสนใจมากมายเยอะแยะเลยนะเชิญค่ะเชิญมานั่งข้างหน้าเลยค่ะเชิญคนข้างหลังนี่เชิญมานั่งข้างหน้าได้นะตอนนี้ขอพูดภาษาไทยก่อนพร้อมแล้วนะคะ So good afternoon everyone. Today we have a great honor to have such a very best speaker for palliative care comprehensive integrated in the health system, the experience sharing from Singapore. And today we have three speakers. I would like to introduce you. The first one is Dr. Achilles-Varan Ramaswamy. Okay, so please maybe just stand up. Yeah. Dr. Ramaswamy is a consultant for palliative care service, Department of Geriatric Medicine in Kutek Hospital. a very good hospital in Singapore. And he has been to Thailand as a member of the Asia Pacific Hospice Network and is a fellow of the chapter of palliative medicine physician from Academy of the Singapore. So he is an expert in palliative care. So he will tell us about the health care system in Singapore and also how palliative care has been integrated to the system. The second speaker will be a very beautiful lady from Singapore. So, Miss Sim Lai Kiao. And I think she is like the Singapore country, you know, because it's something like a pocket Venus. Pocket Venus. Very beautiful ladies, but very small, tiny girl. And she is a nurse clinician and also the coordinator and trainer of the advanced care planning. Her special interest lies on the spiritual care and education for palliative and the end of life care. So it's very interesting. So she will tell us about the palliative care in the different setting of the health service delivery, like the hospice, like the home health care, and include the hospital. And last but not least is, I think he is very handsome man. It is Dr. Lawrence Tan. Dr. Lawrence Tan is an associate consultant with our palliative care service, Department of Geriatric Medicine, and has traveled in Asia Pacific region as part of his missionary work. He is also the Deputy Director of Geriacare North, which is a nursing home project and the advanced care planning office, because you can see he's quite very young, so he will show us the advanced telemedicine. We will have kinds of the live televised from Singapore. When he will present us the live televised from Singapore, so we will see some kind of the activities in Singapore. So that is very, very exciting. I like to start with Dr. Brahma Swami. So maybe just please to, yeah, please. Okay. Yeah.
Thank you, Madam Chairperson. Before I start, I'd just like to thank the organizers of this first international conference, Cancer Control in Health Equity in Royet. It's been a pleasure and an honor for me and my colleagues, the two of them from Kutekwat Hospital, Singapore, and it's been a very enjoyable journey so far. Thank you for your hospitality. What I'm going to do today in the next 40-45 minutes is try to share with you. I'm going to speak in English, okay? Because I don't know Thai. Sawadee-ka, yes, nothing more than that. Okay, so please bear with me. I might speak a bit fast because I have a lot of things to cover. So what I will share with you is Singapore's journey in the healthcare system, how it has evolved over the years, and how we have tried to integrate palliative care into the mainstream healthcare system. There may be some similarities in what is happening in Thailand, and there may be some things you can learn from the process that we have been through, so that you don't have to go through the same difficulties or challenges when you are setting up your palliative care services. I know that in Thailand, palliative care is not new. There are many places where palliative care is reasonably well developed. So I will also share with you some reports from the world which show where Thailand stands and how you can think about it for the future. Okay? I also want to stress, today morning I think Professor Charas made a very interesting statement. He said that it is good for us to be proactive rather than being reactive. So it is good if you have an emergency, you react to that situation. But when we know that we may be facing with emergencies in the future, it is good to be proactive and try to prepare for those challenges that we may have in future. I was quite surprised by what is happening in Royat about cholangiocarcinoma and the challenges that you have with it. So you got to look at how palliative care can help these patients, your own patients and patients in the region. I was told that the health region number 7, population is about 5 million. Singapore's population, if you look at the actual population, is between 4.5 to 5 million now, slightly more with the people who come and go out of Singapore all the time. So the populations are similar, but your land mass, your area is very big. So you got to see how you can integrate palliative care, which can include for patients who are early in the disease and also who are in the late stages of the disease. So please don't equate palliative care with end-of-life care only. You can use palliative care, the principles of palliative care, the principles of symptom control, even for the early disease patients. I think this is something which you have to know. You may want to refer to the article which came out in JAMA a few years ago from Harvard Medical School, where they showed the integration of palliative care in advanced lung cancer patients not only improves symptom control and quality of life for the patients, but it actually prolongs the patient's life, though not very significantly, but it does, compared to those patients who did not receive palliative care. So there are some interesting thoughts that you may want to go through as you look into this. Okay, and we will go through a few things, but let's start with the beginning of how the healthcare system evolved in Singapore. Now, I'm sure many of you know Mr. Lee Kuan Yew was the founding father of Singapore, and he passed away about 1.5 years ago, and when it was the first year anniversary, we had a video which I think actually tells you a bit more about this great man who has actually shaped Singapore. So let's start with the video and then we take it from there.
Our forefathers came here because they were looking for the pot of gold at the end of the rainbow. Some found that pot of gold, many didn't. They sweated their guts out and built this city out of mud flats. We've inherited it. We've added to it.
Maybe we want to stop it and download first.
Our forefathers came here because they were looking for the pot of gold at the end of the rainbow. Some found that pot of gold, many didn't. They sweated their guts out and built this city out of mud flats. We've inherited it. We've added to it. And I say it is worth defending it.
Few million people's lives to account for. And Singapore will survive. This country belongs to all of us. We made this country from nothing. This was a mud flat, swamp. Today, this is a modern city. 10 years from now, this will be a metropolis. Never fear.
This is my country. This is my life. This is my people. You will trample over us, over our dead bodies. We dug our toes in. We built a nation.
So you either have the Western view, you marry the woman you love, or the Eastern view, you love the woman you marry. Well, I tried to match both, and I think it wasn't a bad choice. Without her, I would have been a different man. And a completely different life. At this moment of the final parting, my heart is heavy. With sorrow and grief.
I think it's okay. I think we can stop the video because I don't think it's playing well. It's okay. Yeah, no, this. Sorry.
ปิดวิดีโอได้แล้วค่ะ
Of living country effectively, efficiently, successfully, bearing the interest of his people in mind all the time.
Today we mourn Lee Kuan Yew's passing, but forever we will celebrate the life of this great nation builder.
关押先生是受到国际社会尊重的战略家。
มีปัญหาทางเทคนิคเล็กน้อย
We are sorry about this. Just you bear with us for 2 minutes.
亚洲同世界的交流做出了突出贡献。
Due to his unwavering determination and
มีปัญหาทางมีปัญหาทางเทคนิคเล็กน้อยนะคะ แต่ว่าอยากจะเรียนให้ทราบนิดนึงว่าเมื่อกี้เนี่ยเป็นวิดีโอของลีกวนยูซึ่งถือว่าเป็นวีรบุรุษของสิงคโปร์เราก็จะมองเห็นว่าเขาเนี่ยเป็นคนที่คนสิงคโปร์รักมากเพราะว่าเขาทำให้สิงคโปร์เนี่ยเป็นประเทศขึ้นมา
Maybe I will continue while the audio has come. Basically, what the audio was the video was trying to convey is how Singapore developed from a very simple kind of a place to a totally very undeveloped country to a well-developed country. So it took the vision of one man, which is Mr. Lee Kuan Yew, to come to where we are. But more importantly, Mr. Lee Kuan Yew had a big role to play in the development of the healthcare system, which is what I think the focus of this talk is. So what did Mr. Lee Kuan Yew do to develop the healthcare system in Singapore? So he said that when he was a student at Cambridge, he saw the benefits of the national health system in UK. So he would go to the doctor, he would go to the dentist, he would go to the optician, he would get the medicines, he would get his dental thing done, he would go get his spectacles, but he didn't have to pay anything. It was all free. Like what you do in Thailand now, the healthcare system was basically free to the patient. So he felt very good about it. He felt this is a wonderful system. But when he came to Singapore, he realized maybe the system may not work in Singapore. Why did he say that? He saw that when patients went to a government clinic, right? A government-run clinic, and suppose they had an infection, so they would be given 5 days of antibiotics, right, by the doctor. What the patients will do, they will take for 3 days and stop the medication, think it is not working. So they will take only for 3 days, throw away the 2 days medications, go to a private practitioner, take the same medications again, and then continue the whole medication for 7 days, and then they think they are cured. So he knew that there is going to be a lot of wastage in the system. Okay? So this is something which he saw. So this is the slide which tells you what happened when he was a student in Cambridge. And then okay, not my day today. Anyway, yeah, okay. It's working. So what he says is something very, very interesting. My first lesson came from government clinics and hospitals. When doctors prescribed free antibiotics, patients took their tablet or capsules for 2 days, did not feel better, threw away the balance. They then consulted private doctors, paid for the antibiotics, completed the course, and recovered. So what is happening here? So when they're given free, they don't complete the course, they pay money, take the same medications again, complete the course, and they feel they have recovered. So he felt that this is not something which is going to work. So he wanted affordable health care for all. This is what he wanted for Singapore. So in 1983, almost 2 decades after we got independence in 1965, the first comprehensive health plan was introduced. And what did this do? It presented the government's broad health development strategies, keeping healthcare affordable, meeting the demands of a population which was growing very fast, and also meeting the rising expectations of a society which was getting very affluent, very rich. This may be similar to the problems that you might face here in Thailand, because as the society becomes more and more rich, or more they can afford a lot of things, the expectations are also going to go up. This is something that you may have to think of, how you are going to deal with this. So what happened in 1980s? They restructured all the public hospitals. So they were given more autonomy to function almost like private hospitals, but they were under control by the government. Majority of the hospitals were corporatized in the 1990s. And the goal of this particular exercise was to allow the public hospitals to compete with one another. So it was always almost like a private hospitals competing with one another. So unsubsidized wards were meant to serve as a benchmark in terms of quality and price for the for the private sector. So he was trying to introduce an element of competition within the hospitals, a healthy competition where everybody benefited and the patients benefited, and the systems also grew better and better. So these actions helped the system especially stabilize the prices throughout the system. So the public, the private, and everything else, they had to be very watchful of what the systems were like. I know I think it's a bit noisy on the left side, but I hope you can hear me. Okay, the Ministry of Health owns all the public hospitals, and they formed a corporation called the Health Corporation of Singapore. It was set up in 1985. This Healthcare Corporation of Singapore became MOH Private Limited, MOHH Holdings Private Limited. Government still has control because they appoint the board members and also the chief executive officers. So even though the public hospitals are independent, there is still a kind of governance and a control by the government at the top management. So the management, the senior management is accountable to the board, and the government can still control and give some authority to the overall strategic decision making. This is an interesting slide. So initially what the Ministry of Health did, MOHS, they separated into two clusters. The debate was, who is a better administrator? Is a doctor a better administrator, a medical doctor a better administrator, or for controlling and running a hospital? Or is a non-doctor a better administrator in controlling the hospital? So to experiment this, among the two clusters, one cluster they made a doctor the chief executive officer, and for the other cluster they made a non-doctor the chief executive officer. So one cluster, CEO is a doctor, one cluster, the CEO is a non-doctor, to see who can manage the hospitals better. And do you know the answer? Because down the years we know who can manage better. Anybody guess who manages better? Doctors or non-doctors? Hospitals. The doctors will say the doctors manage better. The non-doctors will say non-doctors manage better. But actually there is no real answer. It is still evolving. I think in some cases you can say doctors manage pretty well, and in some cases you can say the non-doctors also manage pretty well. So it is still an experiment which is ongoing, but it is something interesting as far as management principles are concerned. So the two clusters, you have all the three. You have primary care, you have secondary care, you have tertiary care, and you have quaternary care. So you start from the community where you have the polyclinics and things like that. Then you go to secondary care where you have the general hospitals. Then you go into more specialized care where again the big hospitals are there. And then you go into very subspecialized care where you have the fourth layer of hospitals. Right now we have 6 regional health systems. The 6 actually will become 8 pretty soon. This is Singapore General Hospital. So you can see that you have some of the old iconic buildings which are still there, and then you have the modern buildings which are surrounding it. So we are trying to preserve the culture and the history of how this modern healthcare system developed in Singapore. This is the National Cancer Center Singapore. This is a fairly new hospital, and this new hospital is actually going to be toned down and going to be another new structure. So this is about the general health services in Singapore. Now let's look at palliative care services in Singapore. Some of you who are familiar with palliative care may know Dr. Robert Twycross. He was from Oxford. He just retired a few years ago, and he was also my first professor in palliative medicine. And the first textbooks that I read were written by him. He made a very interesting comment, and I think this is something for all of you to think about. All those of you who are in palliative medicine, if you ask, are you compassionate? Everybody will say, yes, I'm very compassionate. But he said, sometimes to bring about a change, only compassion is not enough. Right? He says, you need to have that anger in you. The anger and compassion is the catalyst for change. So you're very compassionate, you see a lot of patients suffering, but you just don't do anything, then that is not going to make any difference. It's not going to change the system. So you have to feel angry enough to want to make a change. And I think that is what he was saying. He was not saying anger for the sake of anger, but use the anger you see when you see patients in pain, when patients do not have enough symptom control, and how you can give them better symptom control through this. For the Singapore, it all started with a few of these people. Dr. Anne Merriman was from Ireland. She came to Singapore as a geriatrician, and she wanted to set up some palliative care services because she saw the need for it. And this is way back in 1985. She worked with Dr. Cynthia Go, who is a pioneer for palliative medicine. She's a professor of palliative medicine in the National Cancer, associate professor in National Cancer Center, Singapore. Sister Geraldine, who you actually see here. Sister Geraldine is a nun, but she's also a nurse. So the three of them, Dr. Anne Merriman, Dr. Cynthia Go, and Dr. Sister Geraldine, set up the first kind of palliative care services where they did home visits for patients in what we call St. Joseph's Home and Hospice. So they saw patients who required the service and they used to go and visit the patients at home. Then they set up the first service in Singapore in 86, 87 in Assisi Hospice. Then HCA Hospice Care came into the picture in 1987. And so that is how it grew in Singapore. We have Singapore Hospice Council, which is the umbrella body, which is the voice for all the hospice services in Singapore. So you have the logo, which is what we call the Three Hearts logo. So it actually symbolizes three values, which is love, care, compassion. The three services, which is the home hospice, the day hospice, and the inpatient hospice. So inpatient hospice is where patients go and spend the last days of their life, or they may get better and come back home. Day hospice is those patients who are actually fit to go and spend a day in a center, like a daycare center. They're taken care of there so that the caregivers can get some respite. And then, of course, you have home hospice where teams go out into the community. So Sister Sim will speak a bit more about this when she comes on next. The Three Hearts also symbolizes at least the three professionals who are mainly involved in this kind of work, which is the doctor, the nurse, and the psychosocial worker or medical social worker. Palliative care training, and this is where probably Thailand has to look into quite deeply of how we are going to integrate this into the medical curriculum, the nursing curriculum, and the teaching for psychosocial medical workers, and even volunteers. So in Singapore, we have a graduate diploma for palliative medicine in place now. Though it is aimed more at the general practitioners, there are other doctors who can take too. There is, of course, the advanced ASTs, as we call it, and where you can have people specialized in palliative care. And so you have to go through the system. You may have to go through a certain specialty because palliative care is still a subspecialty in Singapore. So it can be done, and you have to do it if you want to spread palliative care across Thailand and even in your region. Same thing for nurses. You have to develop attachments, you have to develop courses, and also have advanced diplomas where the nurses can train. For social workers, also same thing. Think about the volunteers. If you want volunteers to work in palliative care, you also have to guide them and train them. You cannot expect them to do the work without at least basic training. So this is something for you to think about. I'm not going to go into this because I think there is a bit of a problem with the internet, but there are different papers which maybe you can see the slides. And so what I'm trying to show through these slides is Singapore first developed a national strategy for palliative care in 2011. So the national strategy was set up, and a committee was set up to write the national strategy. So we did that. It took about 2 years to do that. In the next 2 years, we worked on how to translate that strategy into implementing it in the community. So we developed guidelines. We won't call it standards, but these are guidelines which different services has to follow. So national strategy for palliative care, then we developed the national guidelines. Now we are in the process of implementing the national guidelines for all hospitals, inpatient hospices, and in the community. So there are different categories, A, B, C, and you can look up the net for it. If you look at the last one, there was a study which was actually put up by the Lien Foundation and by The Economist, and they looked at how the different countries rank. They call it the death index, how the different countries rank across the world in looking after palliative care. Singapore, which was quite low down, actually moved up the ladder. Do you know where Thailand stands? Thailand right now is number 44. So you're quite low down in the list, and you have to start looking at how you can move it up. And you should have a national strategy, you should have guidelines, and you should have a process for implementing. Then slowly, obviously, you can move up. If you look at the Asia Pacific region, Singapore is not number 1. Taiwan is number 1. And Taiwan has done much better in certain areas than even Singapore. So I'm sure Thailand also can do better and move up this ladder. So please refer to the death index, and if you look at the economics, and you will find it there, or Lian Foundation. So these papers are there. I wanted to show you the papers, but I don't want to do that right now. There are, of course, different services in Singapore. So we have palliative medicine departments and units in 7 different hospitals. We have home hospice services which are there, and Sister Sim will show you a video of that. We have day hospice services, which you also will see some, and then of course you have inpatient hospice services. So this is something which you can start looking at even in Roy Ed. I suggest that you start with the home hospice service so that you build up a volume of patients. At the same time, you can have an inpatient service, and then slowly you can think whether you want to have a day hospice service or not. So all this takes time, but you have to start. So I was glad to hear that you have a palliative unit which has already been functional for 1 year or so. We are going to visit it tomorrow, and hopefully we can share some of our experience with them. Let me just quickly tell you how these services integrate with one another. So this is Mr. Tan, let's call him Mr. Tan, and he was a 67-year-old man. He had metastatic prostate cancer. So you can see the bone scan here, and you can see that multiple bones are already involved. So he had his diagnosis made when he complained of increasing backache. He first went to a general practitioner who obviously thought that this was more than what he thought it was. So he got some investigations done. When it was shown to he probably has cancer, he was sent to the National Cancer Center, Singapore. So for there, they started all the regular treatment, the hormonal treatment, and everything was started. Radiotherapy was also planned to the spine so that he can control the pain, because he had back pain. And so they consulted the palliative medicine team, which is a palliative medicine department in the hospital. So they called him, and they were controlling the pain also. So the palliative medicine team, they started the analgesics. The back pain was controlled after local RT. Then whatever analgesics was titrated on, they were titrated to the required doses. And as the disease became more hormone resistant, obviously we knew that he probably will need to spend a lot of time at home. So they referred to the home hospice team, and they supported this man and his family till the patient passed away a few months after that. So you can see the process started in the community with the GP, then went to the National Cancer Center, which is the tertiary center for cancer care. The palliative medicine team got involved. Once the team felt that he can be managed at home, they sent the home hospice service, and then the home hospice service managed the patient in the patient's own home till he passed away. So they supported the patient, but also supported the family, which is very, very important. So that was a 67-year-old man. Now what about a young patient? So here is Miss Sylvia, who is a 14-year-old girl. She had soft tissue sarcoma of the leg, and this was diagnosed more than 2 years before that. So she completed chemotherapy and radiotherapy, all that needs to be done. But as the disease progressed locally, she had to undergo amputation. But by then, she was already found to have metastasis to the lung. And this is very common if all those who deal with, osteosarcomas, chondros, that these things are quite common, okay? And then, of course, because she was getting very symptomatic, she was referred to the home hospice team, because the patient preferred to remain at home, and the mother also felt that she wanted to manage the patient at home. The home hospice team tried their best, controlled the pain and also the breathlessness because of the metastasis in the lungs. So the nurse, the medical social worker, volunteer, they supported not only the patient but also the mother. And then they also helped the patient and the family to come to terms with what was going to happen to the child, the 14-year-old girl. Okay? of course, when the symptoms increased and she became very breathless, and the mother was getting very tired looking after her, they admitted her into an inpatient hospice where the symptoms were controlled, and when she was fit to be discharged home, they discharged her back home. And then she actually passed away in the home about 6 months after that, and there was a home hospice team which was involved. And here also, so 14-year-old girl treated, hoping to cure her for her osteosarcoma of the leg, and then disease progressed. She was referred to the home hospice team. For symptom control, she went into the inpatient hospice, went back home, supported by the team, the home hospice team, and she passed away at home. So the patient was supported both by the hospice team, and the mother also was supported by this team. Of course, the nurses, the doctors, the medical social workers, and probably the volunteers were involved too. So this gives you how these systems can work over the place. A quick word about the financing. How do you finance these systems in Singapore? So you heard Mr. Lee Kuan Yew, he was a bit worried that if you give everything free, there may be a problem. So we usually we look at how individual financing can come into the picture also, So the government subsidies are usually given to keep the basic healthcare services affordable, and also patient co-payment. Co-payment is is a part of the process, so it can be anyway up to about 10% of the cost is actually paid by the patient themselves. So how does this happen? So you have the first tier where the hospital subsidies, the government subsidies will kick in. Then the patients can use their own savings, what we call MediSave, which you save. As you're employed, you actually will pay a part of your salary goes into this fund, which is called the MediSave, which you can use when you're sick, when you're hospitalized, or even for outpatient services. Then you have an insurance program which covers a more critical kind of problems. So where the health expenses are a bit more, the insurance will kick in. And then if you have elder shields and things like that, if you want to cover critical illnesses for certain diseases. So it is basically what we call 1S and 3Ms program. So first S is the subsidies, then you have MediSave, MediShield Life as it is called now, and MediFund. MediFund is actually a safety net. So those people who don't have any MediSave, who don't have any MediShield Life, and they are quite poor in the sense they are cannot afford the bill, then the MediFund will kick in. Of course, they will look at all their what we call the means test, and then it will be decided whether the MediFund can come, so that no person is denied the healthcare services required because he or she cannot afford it. That is what the government wants, that everybody gets the health care that he or she requires, and payment or the cost should not come in the way of that. Okay, so that is how it works. So this is how the subsidies work. So you can see in Class A wards, which is usually the highest category of wards, the subsidy level is 0%, but it can go up to 80% in the C category wards. Different categories for different, different subsidies for different ward classes. Okay. Let me just give you an example of how it works. So that was in the acute ward. So if you look at the community hospital, the subsidies may go up to 75%. So you have different percentages of subsidies given for Singapore citizens. You also have for permanent residents. The others will have to pay the full cost. Okay. So based on what their income is at different levels. So if a patient's annual household income, is between $0 to $700, they will get up to 75% subsidy if they are a Singapore citizen, and they may get up to 50% if they are a permanent resident in Singapore. If their annual household income, per capita income is $3,101 and above, they get 20% for Singapore citizens and 10% for permanent residents. This is actually reviewed from time to time because inflation and all the other things that happen, you make sure that this is even relevant at that time. Okay? Give you a quick example for a patient, actual patient, which can happen. So here is a patient who has an income of maybe $1,101 to $1,800. He falls in that category, and he's transferred from an acute hospital to a community hospital, subacute palliative care, and the bill could be like this. So the total charges may come to $6,800 plus dollars. He or she gets a government subsidy based on what we say here. So he gets 50% subsidy there. And then, so the subsidy will be $2,900 plus dollars. Medishield Life will give $3,194. The Medisave claim can be $670. Out-of-pocket payment for this patient will be $23.34. Now let's look at a patient who probably household income is much higher. Here it is $3,101, and the bill is the same. So the government subsidy will kick in only 20%, so he gets 1,000 something from there. Medishield Life, which is the insurance plan, gives him the $4,700. Medisave, the expected claim is about $842. Out-of-pocket payment is still $23.34. So for both the patients, the out-of-pocket payment still remains the same, no matter what their income is. So that is how the system works in Singapore. So how it is delivered is, it's a mixed delivery model. Acute care, 80% of all the hospitals are in the public sector. So government hospitals are 80% of all the hospitals for acute care. Primary care, the GPs, 80% is run by the private sector. So most of the GPs run their own practice, either as individuals or in group practice. Okay? Intermediate and long-term care or community care, this is the community hospitals, the nursing home, the hospices. These are usually run by non-governmental organizations with subsidies from the government. So the government also plays a role, but generally these services are actually started and run by non-governmental organizations or charities. This is the hospital that the three of us work in. This was KTPH, which was opened in 2010. We call this hospital in a garden. So you can see there is a lot of trees everywhere. There's a lake, which is the Yishun Pond, which is close by. Then you have gardens in every floor. It's a very nice hospital, and some of you come to Singapore, you're welcome to come and visit it and see what we do. This is how the regional health system works. So you have the acute hospitals, you have the community hospitals, you have the nursing homes, you have the rehab centers, and then you have the palliative centers. We also work closely with the polyclinics, the family physicians, and the screening and prevention also becomes a part of it. So in the morning we were talking a lot about screening and prevention. Yes, it's important, but at the same time you should look at how palliative care also could be integrated into the system as you develop your screening programs also. You should not be developing only your screening programs and say, let's do the palliative care later. It may be too late. If you want real integration, both the things have to be done simultaneously. In Singapore also, I think initially a lot of focus was done on the acute hospitals, but now the government is very, very supportive of palliative care. So these are the 6 regional health systems, and this is the health system in the hospital that we work in, the KTPH. So we have Yishun Community Hospital, we have an old folks home, we have a nursing home, we have community-based center, we have polyclinic, we have GPs, we have medical center. So the whole, if you look at it, it's a whole ecosystem that has to be in place so that the patient can be supported no matter where the patient is. Just give you a quick example of community care. So the patient may have an acute problem and come into the acute hospital, KTPH. So he may be suffering from a stroke. He comes in. As soon as we stabilize the patient, we think the patient is fit to go into the community hospital for rehab, the patient will be sent to the community hospital. Once in the community hospital, the patient is comfortable and now the rehab is complete and can go home, the home care team will follow through. So there is a community care team, we call the CCT, and these nurses will go into the home of the patient to take care of him at home. So the patient is not left alone, or the family is not left alone to take care of himself or herself. Of course, you need a good IT system, informational technology system to cover all this. Still not perfect in Singapore because we have different clusters. Each hospital cluster has its own system, but definitely we are still able to see if a patient moves across hospitals, we are able to access the records electronically and see what the patient has gone through. This is still evolving, but you need something like this so that the data is there for you and you don't have to keep asking, calling and finding out what is happening, okay? I will not show you the video. There is a video here, but I think I'm not very sure it will work. So I will just skip it and then we will just go to the 2020 master plan. So Singapore, what it's doing is we have an aging population and we think that we have to be ready looking after this patient. So we call it the silver tsunami. Silver tsunami. So this is something which is going to hit Singapore and it's already hitting Singapore. It's something happening quite rapidly. So we've got to prepare ourselves for it. So what the government has decided it will build hospitals, maybe community hospitals also. So they're already doing that and they are hoping to have at least one hospital open every year till 2020, one acute hospital or a community hospital. They are looking at focusing on nursing home care, they're focusing on the community care so that there is more and more subsidies and more support available for the patients in the community. Singapore is small, it is landlocked, so we cannot keep on building more and more hospitals. It's going to be difficult. So we've got to support the patient wherever he or she is. And if we can keep the patient at home, that would be the best place. And if you look at palliative care, you ask the patients, especially who are in the end of life care, where would they prefer to spend the last days of their life? The answer would invariably, more than 90% of them will say, okay, we wish to pass away at home. But how do we achieve this for them? You need to have the support for the patient and the family so that this wish of the patient to spend the last days of his or her life at home and maybe pass away at home is achieved for them. I think that's all I had to say, and those are some of my references. And we'll be happy to take your questions maybe after the two speakers have spoken. Okay? Thank you very much.
Thanks very much. So to make it clearer, maybe I just like to summarize it in Thai. So for my colleague from Thailand can understand, because your talk just very important, because the system is cover all of the population in Singapore. Nobody left, nobody left. Yeah. So I just maybe just few minutes, Mr. Sim, Miss Sim. ตอนแรกนี่เขาพูดถึงลีกวนยูที่เป็นลีกวนยูที่เป็นเหมือนกับเป็นปูชนียบุคคลของเขานะคะลีกวนยูเนี่ยเขาได้พูดอะไรหลายๆเรื่องที่ทำให้มันประทับใจและทำให้เกิดความมีความรู้สึกว่าจะต้องต่อสู้จะต้องฝ่าฟันเพราะว่าเขาพูดตั้งแต่แรกเลยว่าบรรพบุรุษที่เขามาที่นี่เนี่ยเพราะเขาต้องการมาหาทองกับมาหาสายรุ้งใช่ไหม The end of rainbow แต่ว่าบางคนก็เจอบางคนก็ไม่เจอนะคะแต่ยังไงก็แล้วแต่เนี่ยเขาจะก่อร่างสร้างตัวนี้จากดินโคลนจากโคลนตมที่อยู่ตรงนี้แหละเขาจะทำนะอันนี้ก็ทำให้เรามีความรู้สึกว่าถ้าเป็นอย่างลีกวนยูถ้าเรามีผู้นำอย่างลีกวนยูนี่เราก็สู้เต็มที่นะคะทีนี้สิ่งที่ดร.อาคิลิสวรานรามาสวามีพูดเนี่ยอยากให้คือที่แปลให้ฟังนี่เพราะอยากให้รู้จริงๆเพราะว่าสิ่งที่เรามองเห็นว่าสิงคโปร์เนี่ยเขามองระบบการดูแลทางด้านสุขภาวะทางด้านสุขภาพในอย่างไรนะคะเอาสรุปสั้นๆนะคะก็คือว่ามีอยู่3ส่วนที่เราจะสามารถที่จะสร้างระบบนี้ได้3ส่วนคือ1นี่ส่วนหนึ่งนี่รัฐบาลต้อง subsidize นะอีกส่วนหนึ่งนี่ต้อง co-payment ต้องออกเองนะอันนี้นี่คือของเขานะออกเอง อันที่3นี่คือเรื่องของอินชูรันนะอินชูรันที่จะเข้ามาเสริมเติมตรงนี้ให้นะคะเพราะฉะนั้นแล้วเนี่ยอันนี้น่าสนใจมากเลยนะน่าสนใจมากว่าเราจะทำได้อย่างเขาไหมและสิ่งที่เขาทำตอนแรกเลยเนี่ยเขาใช้ไอ้ palliative care ที่มันจะเข้ามาเกี่ยวข้องกับsystem ทั้งหมดเนี่ยเขาสร้างโครงสร้างขึ้นมาก่อนโครงสร้างของเขาคือ Singapore Hospice Council ตอนแรกเนี่ยเขาสร้างไอ้ตรงนี้ขึ้นมาก่อนนะคะอันที่2คือเขามีเทรนนิ่งนะเขาสร้างโครงสร้างแล้วว่าเขาจะต้องมีไอ้คาวซิลนี้ขึ้นมามีสภาหรือมีองค์กรขึ้นมาเนี่ยอันที่2เขาต้องเทรนคนก็คือเป็นเหมือนกับเป็นทรัพยากรให้ใส่คนเข้าไปนะคะ palliative care training ทั้งหมอทั้งพยาบาลทั้งวอลันเทียทั้ง social worker เลยนะเขาเทรนหมดเลยนะหลังจากนั้นเนี่ยอาจจะพร้อมๆกันเนี่ยเขาวาง national strategy เขาวางกลยุทธ์ของ palliative care and beyond ด้วยนะมากกว่านั้นด้วยนะคะแล้วเขายังมีโครงสร้างอีกอันหนึ่งคือมี setting ที่จะใส่เข้าไปว่ามันควรจะมี palliative care อยู่ที่ไหนบ้างเขาก็มี palliative medicine department ขึ้นมาแล้วเขาก็แบ่งออกเป็น home hospice ก็คือการดูแลที่บ้านนะคะ day hospice ก็คือการดูแลภาคในเหมือน day care อีกอันหนึ่งคือ inpatient ก็อยู่ในโรงพยาบาลนะคะและอีกอันหนึ่งก็คือ home hospice นะตกลงนี่มี setting มีทั้งบ้านมีทั้งโรงพยาบาลมีทั้ง inpatient มีทั้ง day นะมีหมดนะคะแล้วก็นอกจากนั้นเนี่ยเขายังได้พูดถึงไอ้ healthcare protection model นะ healthcare protection model นี่ S+3MS นะ S+3MS ก็คืออะไรอันที่1คือ subsidize คือการช่วยรัฐบาลเนี่ยใส่เข้าไปอันที่2เนี่ยคือเราเนี่ย saving คือ medisave คือเราเอาเงินของเราเนี่ย saving ใส่เข้าไปนะคะหรืออาจจะจ่ายเป็นเข้าไปเป็นกองทุนหรืออะไรก็แล้วแต่นะคะอันที่3เขาเรียก medishield ก็คือ insurance น่ะคือเราก็มี insurance ต่างหากอันที่4คือ medifund ก็คือ safety net นี่ก็คือการที่ cover สำหรับคนที่ไม่มีอะไรแล้วไม่มีทั้ง medisave ไม่มีทั้งmedishield ไม่มีอะไรเลยก็ให้เลยอันนี้ก็คือสังคมสงเคราะห์นะคะนะแล้วอันนี้เนี่ยเขาจะแบ่งเกรดด้วยนะว่าเกรดไหนเนี่ยมีการ subsidize กี่เปอร์เซ็นต์เกรด A ไม่ต้อง subsidize B 20% B1 เนี่ย 20% B2 plus นี่ 50% B2 ไม่ plus นี่ 65% C นี่คือต้องทั้งหมดคือต้องช่วยทั้งหมดนะอันนี้ตามรายได้ของครอบครัวแล้วก็ตามที่เป็น citizen หรือเป็น permanent residence ด้วยนะคะแล้วก็มีส่วนหนึ่งเนี่ยเขาใช้คำว่า out of pocket payment ก็คือต้องจ่าย out of pocket นะคะเพราะฉะนั้นแล้วเนี่ยอันนี้เนี่ยมองให้เห็นว่าระบบของเขาเนี่ยเป็นระบบที่ดีมากเลยนะระบบที่ดีที่มองเห็นว่ามันมีคือสามารถ cover ได้ทุกคนแต่ว่าแต่ละคนแต่ละพวกแต่ละฝ่ายเนี่ยจะไม่เหมือนกันไม่เท่ากันเพราะเขามีระบบไว้อย่างนี้นะคะแล้วสำหรับsetting ที่เขาให้บริการ palliative care เนี่ยนะก็จะมีตั้งแต่ polyclinic ใช่ไหม polyclinic นี่ก็มี screening นะคะแล้วก็นอกจากนั้นก็จะมีเรื่องของ family physician นะแล้วนอกจากนั้นก็จะเป็น community hospital เป็น acute hospital เป็น nursing home แล้วก็เป็นโรงพยาบาลแบบครูเทคพวดนะเพราะโรงพยาบาลแบบครูเทคพวดเนี่ยทำsecondary care tertiary care ด้วยเลยนะคะอันนี้ก็ถือว่าเป็นอะไรที่เขายัง cover นั่นอีกนะเขามีคำว่า old folk home old folk home ก็คือ เป็นเหมือนกับ traditional medicine น่ะเป็นแบบแพทย์แผนโบราณคือบางคนเนี่ยเขาอาจจะเชื่อเรื่องสมุนไพรเรื่องอะไรก็แล้วแต่ที่เป็นแผนโบราณนะอันนี้ก็ใส่เข้าไปด้วยนะคะอันนี้ก็ถือว่าเป็นอะไรที่มองเห็นระบบทั้งหมดของเขานะคะและนอกจากนั้นที่ดีมากๆอีกอันหนึ่งของเขาคือเขามี 2020 Master Plan นะ4 ปีข้างหน้ามีละ Master Plan ว่าจะต้องทำอะไรบ้างเขาจะต้องบอกว่าจะต้องมีความหวังว่า easier access better quality ใช่ไหม improve primary care more affordable นะคะคือทุกอย่างเนี่ยมันต้องดีขึ้นหมดเลยดีขึ้นหมดเลยเพราะฉะนั้นเนี่ยเขาถือว่ามองไปข้างหน้ามองไปข้างหน้าดูระบบให้ดีแล้วก็มองไปข้างหน้าทำแผนสำหรับ 2020 ด้วยเลยนะคะอันนี้ก็ถือว่าเป็นเรื่องที่ดีมากๆไม่ใช่ที่ palliative care อย่างเดียวนะ the whole system the whole health system นะคะ so I just try to explain them because it's very very good and it is very knowledgeable for us to know it because maybe some people they don't clearly understand what you talk. Okay. So, okay. สำหรับคำถามเดี๋ยวถามทีเดียวเลยนะคะถ้ามีอะไรก็ถามได้ทีเดียว So thank you very much for your contribution. Yeah. So the second speaker is our pocket Venus, Miss Sim Lai Kiel. She will tell us about the details in palliative care in home hospice and also the hospital. Okay, so please.
Good afternoon. Thank you. I think I want to thanks again for the organizer session to invite us, and we are really, really honored to be here, especially for your first international conference for the cancer control. I think Dr. Akhilesh mentioned about challenges. I think in life we got a lot of challenges we face, and I heard that Riot just started the palliative care service only last year. But just remember, challenges is what make life interesting. But challenging, forthcoming, we are facing them. Challenges is what make life interesting. But forthcoming them, all these challenges is make life meaningful. So I'm sure y'all can do it, okay? So today we'll share and see how from our talk y'all can get some hint and wish y'all all the best there. So my talk today is about palliative care and hospice care services in Singapore. I hope my video works afterward. Okay, what is palliative care? So just now, Dr. Akhilesh said, palliative care in Singapore is a specialty. So it's a specialized medical care for people with serious illnesses. And it is provided by a multidisciplinary team who work with patients, other clinicians to provide an added layer of support. That means because a patient, when diagnosed with advanced illness, encompass multi-dimensional issue, and all these multi-dimensional issue need a multidisciplinary team to solve, because one person cannot solve the issue. Okay, and it is appropriate at any age, at any stage, and can be provided together with curative and disease-directed treatment. That means that palliative care can be referred earlier when the patient is diagnosed with advanced illness, but still go under treatment, still ongoing treatment, and not to refer when they are really at the end. Because I was just sharing with our friend is that when we first started palliative care in acute hospital, a lot of referral that come to our service is a very late stage. And even sometime when I first started my palliative care nursing in 2002, when I go and say hello to my patient, before I can introduce my patient, the patient died in front of me. I can't do much thing. So, but now it's good. We have educate other discipline, and now we get referral earlier, whereby we make friends with the family and the patient. We get to know them, and they still go for treatment like chemotherapy, radiotherapy. And when this treatment failed and they really on the end, we play a bigger part. That's what WHO said. It's an approach that improves the quality of life of patient and family, not only patient. We must involve the family, facing the problem, and also through the prevention and relief of suffering by means of early identification and impeccable assessment, treatment of not only pain, other problems. So as what I said, it's a multi-dimensional problem. They got physical, psychosocial, and spiritual pain, which we what we call a total pain. And as what just I mentioned, palliative care is not just awaiting when the patient is dying at the end. It's a total active care. Active care means that patient under palliative care still we do things for the patient. And management of symptoms is really very important, either by medication or non-medication. Because as what a lot of my patients who come to us under, sometimes we ask them, are you afraid of dying? They said no, they are not. What they are afraid is pain. A lot of them, 10 of 10, always afraid that they die in pain. So palliate the symptom is very important. And also we talk about psychosocial and then spiritual distress. I'm sure when a person is being diagnosed with advanced illness, when they are at their end, their last journey, there's a lot of question. Why me? What's the meaning of life? Or the spiritual issue. And we also do investigation for some, because some of the issue, some of the problem that arises for our palliative care can be reversed. So certain investigation we need to do so that we can solve the issue. For example, hypercalcemia, we need to take blood. If the patient got hypercalcemia, we can be reversed certain symptom. Okay. And also we teach the skills and then teach our healthcare staff. And so this is the 3 essential components of the terminally ill patient. Just now we were saying you got physical, psychosocial, spiritual. So we need symptom control, we need psychosocial support, and very important, teamwork and partnership. And all these issues cannot be settled by one person. So we need multidisciplinary team. And you can see the circle. We got doctors, nursing staff, OT, occupational therapy, social worker. We got community caregiver, volunteers, support staff, and dietitian, which play a great part. And also we have our clinical psychologists, and we also got physiotherapy. And don't forget, the patient and the family is our team member. Okay. As what just now I have said, a good palliative care principle is symptom control, psychosocial care, and disease-directed care. And we need all this multidisciplinary attention to details, anticipate problem, psychosocial care, and meticulous review and reviews. Okay. So this slide to, because this morning when I heard other speakers speaking that the common cause in the death in Thailand also is cancer, correct? Yeah, and but you are more on the cholangiocarcinoma cancer. Ours also, you can see the chart, cancer also is the first killer in Singapore. And the most common one, the cancer is, for males, is the colorectal cancer. It's the first. And then the female is more breast. Breast followed by also colorectal cancer. But I also heard you have this screening for female. So for us in Singapore, female also go for mammogram, go for pap smear, yearly, 2 yearly. We have all this screening program. Okay. So for now to introduce the palliative care services in Singapore, I think we are quite fortunate that we have quite good services in Singapore. So our palliative care service, we can be done in hospital, we got inpatient hospice, we got home hospice, and we also got day hospice. So it's under the Singapore Hospice Council, which Dr. Achilles shared just now. So our inpatient hospice, we got four hospices in provide to allow patients to stay in this small little hospital. And I think Dover Park Hospice is the biggest at the moment with 50 beds. The other hospices are smaller, but they are expanding. Okay, and we also got home care service. We got a few home care service, 4. We got more. We got 4 hospices. And all these home services means they have a team of a doctor. I mean the nurses, is more of a nurses lab. And if they got issue, they also got doctor. And these services are free, no charge. No charge, yes. And we have 2 daycare service, hospice daycare, whereby certain time, nowadays our Singapore, the family unit is very small. So certain, the family only got 1 or 2 children, and some of them, most of them, they work, you see. So if let's say they are home, they got an elderly or a person down with advanced years, but they still able to ambulate a bit, can walk. And the family go to work, and this patient might be alone at home. So we have this daycare, whereby the morning we got this transport to fetch them to this daycare. They got activity, they can sing karaoke. Sure you all like to sing karaoke. Activity, some PT, all this, and about in the afternoon, the transport will send them back. So that when their family come back from home, they can take over the care. So we have this type of daycare service for them. And also hospital-based services, I think, looking at the list, most of our acute hospital, we have palliative care service. We have. Then we also got community hospital providing palliative care. And one of them is Yishun Community Hospital. It's just our neighbor, like our brother, the same site. Kutek Puat and Yishun Community Hospital. And we have a ward. Just now I was sharing, we have a ward of 16 beds at the moment. And the AIC home care, we got another service called AIC home care, also home hospice providing for non-cancer patients. Those patients with end-stage renal failure, end-stage heart failure, we have this AIC home care, the same. And then we have some private agency also running home care service. So I would like to introduce you what we do in our hospital, in the acute hospital setting in Kutek Puat. So you can see the chart, we got a lot of services. Means when the patient referred to us, our team will see. So my team consists of, just now I spoke to, we got a social worker, dietitian, nurses, doctors. We are a multidisciplinary team. So we provide things like, we liaison with other services when the patient go home. We do discharge planning. We hold a lot of family conference. Because a lot of time when the patient is diagnosed, there's a lot of questions. And sometimes family very lost, don't know what to do. So family conference, we keep them update their illness. We give them information. We discuss about choices, what is best for them. Then we also got psychosocial issue. Then we also got physical symptoms control, which is very, very important. So we use drugs like opioid, like I'm sure you're also using, like fentanyl, morphine. Those are sometimes the patient or the family themselves, they got this misconception about like when we start opioid means am I dying? You know, or my family, is he dying? So sometimes we start opioid morphine or they thought that they are dying. So we have to explain the important, the side effects to them. And we also do advanced care planning, and I'm glad that I spoke to some of the nurses. You're also doing very well on advanced care planning in the hospital. And one of the things that we do is terminal discharge. When you see, I don't know whether you all do this here, but as what Dr. Akhilesh said, a lot of ill patients, they want to spend their last day at home. So in our hospital, if the patient's condition deteriorates, and we know that death is near, even for only a few hours before they die, and if they wish they want to go home, then we'll do all the terminal discharge. We arrange for them, we caregiver train them, the family how to take care, then we let them go home. We liaison with the community help to follow up, because sometimes death, we thought that we are not God. Sometimes we cannot specify that this patient will die this time, correct? So sometimes we thought they are dying, but when they go home, they don't die. So if they don't die, then they need some support. But some of them, they really, really wait to go back. And my shortest patient that go back is just go back and lie in their bed and they die. They just wait for that moment. So we have all these service to support them and teach them what to do. So our hospital, previously, we are more of a consultative service. That means if other discipline, for example, the general medicine, the surgical, the surgeon or the neurosurgeon or the geriatric, even the geriatric service, if they got patients who need the palliative care service, they will consult. That means they will refer to us. Then we will come in. And I think a year ago, in the geriatric ward, we took out about 5 beds so that those complex cases, more complicated cases, we take them over to nurse under the palliative care team. Then we also have outpatient clinic. So like Dr. Akhilesh, Dr. Lawrence, we run clinic. So the patient come back for TCU, means follow up. Okay. I also would like to just share a case with you all to walk you all through what we mean just now, what I have said, how we refer to the home team, what we do. So this auntie, Madam Lee, is quite young. She's a taxi driver. She drives taxi. She's only 55 and she got a gallstone disease. And she was referred to us because of symptom, very pain symptom and end of life care. She's married with 2 children, a son and a daughter who are single. So she was diagnosed with cancer, bile duct cancer in 2012, and she started oral chemo. It was quite well in a way until 2014. She got a lot of lymph nodes. So they did a biopsy and find that it's recurrent and all already metastasis to the lymph node. She came was admitted and then she got shortness of breath. You can see the x-ray, they got a lot of poor fluid in the lungs. That's why she's very breathless. And just now I said that patients who are under palliative care, we still do treatment, we still do things for them. So Madam Lee was being referred to the radiologist, then they put in a tube to take out the water, the fluid, so that she's less breathless. So we did that. And unfortunately, her condition deteriorated. And then during this time, we did advanced care planning with her. I'm sure, I don't know whether you know what is advanced care plan. It's more or less, we plan for future treatment care when the patient is still able to make decision. We want to sit down with them to listen to their concern, listen to their preferences, what is important for them, what is meaningful for them. So we have advanced care planning done for her, and her concern is that she wants her symptom to be controlled. That's number 1. 2, because she knows her time is short, and she only got a daughter who is quite young, was not married. So she wants the daughter to have someone so that when she left this world, she is assured that somebody is taking care of the daughter. And the daughter got a boyfriend. So we spoke to the daughter. So during the advanced care planning, the daughter want to bring forward the engagement. So at least have a grand engagement to assure Mama that, oh, I got someone with me. If you are not around, I got someone to take care. So she got a lot of relatives in Malaysia. So she want to travel to Malaysia to have the celebration. But because she's very weak, so during the family conference, we advise, and we advise is that we ask the relative to come to Singapore instead of she travel over there because it's quite stressful. So they are all agreed. So she had she went home. She went home, and we refer because she's going home and she's quite symptomatic. Although we started on medication and the pain, the breathlessness is well controlled, we still need somebody to continue to follow up. So you will refer to the home hospice. So what the home hospice services do is the same thing as what we do in the acute hospital. They also provide nursing care. They also educate to make sure that the family can cope, and also continue to support them emotionally, socially, and spiritually. And one thing is also the thing that the home hospice, they are very great. They also loan equipment. So they have equipment like a hospital bed. They got commode, they got wheelchair. The family pay a certain small little deposit, and they can loan all this equipment. And so the family no need to go and buy, because certain time all this is quite expensive, and then they might only use for a short term. So they got this equipment to be loaned to them. And then just now what I say is that we have this daycare whereby they go there, they get some therapy, they even go outing, they do some artwork. So before I go into the inpatient, maybe I'll let you all see what the day hospice or home hospice do. Can I just click? Yeah. Thank you. So it works. Thank God.
Son, you are a very good and thoughtful person. Even though you were in pain, you never showed it to us because you did not want us to worry. I am very grateful to HCA for taking care of my son and supporting our family all the way.
Sorry, don't have subtitle.
Don't worry, son. I am in good hands.
Founded in 1989, HCA Hospice Care is a registered charitable organization caring for patients with life-limiting illnesses. We focus on providing relief of pain and other distressing symptoms, as well as ensuring emotional, spiritual, and practical support for the patient and the family. We are the largest home hospice service provider, offering free 24-hour holistic home hospice service. Our dedicated multidisciplinary team of doctors, nurses, medical social workers, and counselors make 40,000 home visits island-wide every year.
When they're asked, where would they want to spend the final days of their life, the answer is almost unanimous, and they would all like to spend it in their own homes. having a service like the home hospice service that HCA Hospice Care provides gives them that opportunity to do so, you know. So we try to support them through our service. We also support the caregivers by training them to take care of the patients while they are in their own homes.
Once we relate to patients, our care becomes more meaningful because we don't treat them as just physical, but we treat them as a person.
就是一点看到不大对啊，好像这样，我们就会，会自己就是紧张这样，所以我们就会打给婉如。第一个我们就打给婉如。
婉如每次他来的时候，他就会进去里面，就会叫我家婆阿嬷，他有时候就清醒，他就会开一下眼睛啊，我家婆也蛮开心的啦。
When you go to a patient's house, you are in fact like a guest to them. So you actually have to get to know the patients, get to know family, get to know their culture, and in a way gain their trust. And I think once you gain their trust, that's where you can really help them and know what makes a difference to individual family.
I think as a volunteers, we should be putting our heart and soul to look after the patient. I touch their hand, I tell you, they hold me tighter because they appreciate what we do.
Our day hospice center caters to patients who are safely mobile and who do not require 24-hour nursing assistance. At the center, patients can interact with other patients and participate in constructive and therapeutic activities such as
spot. It doesn't really work that well. Anyway, this is a service, the home care service. Just now you heard they are on 24 hours call. And really thanks this home team nurses, they really work very hard and they really continue the care when my patient discharge home, and they can assure them that they spend their last day at home. Sorry. Anyway, Madam Lee went home, and then they have a grand celebration for the daughter, the engagement party. And she came back again to hospital because she chose not to die at home. She doesn't want to die at home. So she's afraid that the daughter might be frightened. So she chose not to die at home. So she came back to the hospital very ill, and she was transferred to inpatient hospice unit, whereby she spent about a few days there, and she passed away peacefully with the family at the bedside. I don't know that I got a video on the inpatient hospice, but I wonder whether it works or not.
Maybe
No more. Okay. Okay. So the inpatient hospice, for us in Singapore, just now I show is that we have 4 inpatient hospices, and there's some criteria because the beds are limited. So got criteria for patients to enter this inpatient hospice setting, and most of them, they say their lifespan is less than 3 months, or patients who don't have any family and very, very symptomatic, they will have to go into this inpatient hospice, or even those patients who the family take care and then they are very, very tired and they need some rest time, they can put their loved one in this inpatient hospice for a week or 2 and then bring them home. I think that should my end of my thing. So this is, I'm sure you all saw this verse very, very often in all the palliative care conference, that you matter because you are you. You matter to the last moment of your life, and we will do all we can, not only to help you die peacefully, but to live until you die. I think we are helping patient to live and not helping patient to die in a way. Huh? So when days cannot be added to life, let's add life to their days. Okay? So thank you very much.
Thanks very much. Our pocket Venus. Yeah. สรุปให้ฟังนิดเดียวนะคะเพราะว่าเวลาเราน้อยคิดว่าตรงนี้เราพอจะมองเห็นแล้วว่าที่สิงคโปร์เนี่ยเขามี palliative care แบบไหนยังไงโดยเฉพาะอย่างยิ่งในคนไข้ที่เป็นมะเร็งนะคนไข้ที่เป็นมะเร็งเนี่ยเขามี palliative care service อยู่ทั้ง community based นะคะทั้ง home care service ทั้ง day care ทั้ง hospital based service นี่มีหมดเลยนะคะมีทุกระดับเลยนะแล้วสิ่งที่จะเป็นสิ่งที่เป็นหัวใจของเขาคืออย่างน้อยก็2เรื่องนะคะก็คือ1เนี่ยเขาจะต้องมีเรื่อง symptom relief นะ symptom relief คือเขาไม่สามารถที่จะรักษาได้ทั้งหมดเนี่ยก็ขอให้มี symptom relief นะคะอันที่2คือ psychosocial support นะจะต้องมี psychosocial support เลยที่ว่าทำให้คือถ้าจะเสียชีวิตไปเนี่ยก็ต้องเสียชีวิตแบบสงบร่มเย็นนะแล้วเขาไม่ได้แคร์เฉพาะ patient อย่างเดียวนะ family ด้วยนะเขาเน้นเสมอว่าจะต้องคนที่จะเข้ามามีส่วนร่วมในการที่เป็นทีมในการที่จะดูแลคนไข้เนี่ยต้องมี family ด้วยนะคะเราอย่า ignore คือเราอย่าคิดว่า family นี่ไม่สำคัญเราต้องดึงเอา family เข้ามาช่วยดูแลคนไข้ด้วยเหมือนกันนะคะเพราะอันนี้นี่เป็นอะไรที่เราควรจะคิดไว้เสมอสิ่งหนึ่งที่เรียนคิดว่าจับได้จากการพูดของเขานอกเหนือจากที่เราดูแล้วว่ามีการดูแลแบบไหนยังไงเนี่ยคือสิ่งที่เขาเรียกว่า advanced planning นะ advanced planning เนี่ยมันเป็นการดูแล as a whole รวมหมดเลยตั้งแต่ขณะนี้เรื่อง symptom เรื่องสิ่งที่เป็นที่เขาใช้คำว่า patient unfinished business ด้วยนะคือบางทีเนี่ยคนไข้เนี่ยติดใจอยู่บางเรื่องอ่ะเราอาจจะต้องเข้าไปช่วยดูว่าไอ้เรื่องนั้นเป็นเรื่องอะไรที่เราจะสามารถช่วยเหลือ support ทางด้านจิตใจเขาได้หรือเปล่าถ้าสมมุติว่าเราสามารถที่จะทำให้มันลุล่วงไปได้เนี่ยเราก็คงจะช่วยแต่ว่าถ้าช่วยไม่ได้นี่เราต้อง support ทางด้านจิตใจนะคะแล้วก็เราก็จะต้องมีเรื่องของเนี่ยcaregiver training เข้าไปมีเรื่องของfamily ที่จะนี่เขาใช้คำว่า family conference นะก็คือเข้าไปดูแลfamily แล้วก็ให้ความรู้ family แล้วก็ให้ความเห็นความคิดอะไรก็แล้วแต่เพื่อที่ family เนี่ยจะได้ช่วยประคับประคองคนไข้เนี่ยให้ไปอย่างสงบร่มเย็นจริงๆนะคะอันนี้เป็นส่วนหนึ่งซึ่งอยู่ในที่เขาพูดนะเพราะฉะนั้นจริงๆเขาพูดเยอะกว่านี้แต่ว่ายังไงเนี่ยเราก็จับประเด็นใหญ่ๆเพื่อที่จะเอามาใช้ประโยชน์ในส่วนของเรานะคะก็คิดว่าถ้าจะมีคำถามเดี๋ยวค่อยถามอีกทีละกันนะ Thanks very much.
Thank you.
So the next one will be our handsome doctor from Singapore. So he will show us. I just try. I just hope that if the technical will be not will be try to make it smoothly. Okay, so please.
Okay. Good afternoon, everybody. I'm Lawrence. I'm a palliative care doctor from Singapore. Thank you for staying back. I know everybody is a little bit tired. It's in the afternoon. We're going to talk about our tele-geriatric system. We call it Geri Care at North because Khoo Teck Puat Hospital is in the northern region of Singapore. And this is our team. And as you can see, this is the map of Singapore. We have a total of approximately 5.5 to 6 million people. Our catchment area in the north has about 700,000 people. So these are the areas that is under our catchment. And this is our Geri Care team. And we believe in partnership. So I'm not sure how the healthcare system is like here, but I understand there are district hospital, and Royal Hospital is the biggest government hospital in this region. And the specialization in the district hospital may not be as much as compared to the main hospital here. So similarly for us, we have a lot of patients in the nursing homes. And the nursing homes, nurses are present, but doctors are not. And even if doctors are present, generally the specialists are not. So the question is, how can we give them specialized care without having to be physically there? So I guess technology has advanced, right? Most of us have traveled overseas before. And when we travel overseas and we miss our family, what do? Last time we used to make very expensive IDD call overseas, but now we can use line call, and sometimes we use Skype call to see our families. And the question is, how can we leverage on this technology to help our patients? So we believe in partnership. You see, our main vision, the work is partnership, which means that our role is not to take over the job of the people in the nursing homes or the smaller hospital. Our role is to partner with them and give them the necessary knowledge in order to achieve a better outcome for our patient. So this is Khoo Teck Puat Hospital, as you have seen, and these are the current nursing homes that we are supporting. I'm going to skip through them quickly, but the interesting thing is, in a multiracial place like Singapore, the nursing home consists of almost all the religion that you can find in Singapore. So we have a Christian nursing home, we have a Buddhist nursing home, we have a Hindu nursing home, and we also have a Catholic nursing home. So I'm going to skip through all of this. And our principle remains the same as for all palliative care, is we care for the human being. And we believe that patients are not patients, that patients are human, meant to be respected and meant to be loved. And one of the things that we emphasize is that patients have autonomy. They can choose. Some of them choose to take medicine. Some of them choose not to take medicine. Some of them choose to have a tube for feeding. Some of them choose not to have a tube for feeding. But it's a choice, right? As doctors, as nurses, we can advise, but we don't force them to comply with what we think is best for them. So there are three aims of our TeleG system. The first aim, of course, is to improve the quality of life of the residents. But why we do it via TeleG is because we want to reduce unnecessary utilization of hospital resources. I think I was told yesterday that the hospitals over here are being very full. And similarly in Singapore, our capacity at this moment is about 120%, which means that our hospital is always 120% full all around Singapore. And how can we then support the other groups of patients who are not in hospital at this moment so as to reduce the utilization? So what we do is, of course, there's three components to it. This whole system, even though the focus is on the computer, the TeleG, but it consists of both research, education, and clinical arms. So in simple sake, it's this three. But, and if we break it down, we want to realize that there are four big components to our care, right? Advanced care planning is a very big part. You see, it's one big quarter of our care. Because really, a lot of palliative care starts with talking to the patient and the family. Then, of course, improving the nursing care, training and teaching, and palliative care itself, end-of-life care, takes up another quarter. So it's interesting that while doing palliative care for the patient, the main things we do is not direct palliative care. A big part of it is training, a big part of it is advanced care planning. And what have we shown? So, a UK team visited us and they did health service research for this telegeriatric system. And they find that for a patient to have a telemedicine consult, it costs $45 USD. It's 25 minutes, not 5 minutes. The total time taken is 25 minutes. But if the patient were to visit an outpatient clinic, it'll be 1 hour and it costs $199. And if it visit the emergency department, it will cost $191 and it will be 1 hour 30 minutes. So we can see that it both saves time and it also saves money, which is very, very important. So this is just some pictures to show you what we do. So one of the things we realize after a while is when we do a telegeriatric system, that means we talk to a patient via television, they don't feel a sense of personal touch, which means that they find it very weird, like the doctor is on the other side. Similarly, sometimes we talk to our family via Skype, it's not the same, right? So we realize that there is a need for a physical person right beside the patient, but it doesn't necessarily have to be the specialist. It can be a nurse who knows the patient well. And more importantly, the nurse can be trained in order to provide physical care for the patient. So the nurses are even trained to do physical examination, history taking, and come up with basic diagnosis. So I'm going to skip these slides for time's sake, and advanced care planning workshop. So this is how a telegeriatric system looks like. You can see that the patient is on a wheelchair on one end at the home or nursing home, while the hospital team is in a room taking care of the patient. And not just patient care, we also make use of the telegeriatric system for multidisciplinary rounds, for mortality rounds, for teaching. In fact, at this moment, we have an ongoing geriatric care teaching to nurses in Uganda. So these are some of the teachings that we do. And this is what we do when, with the Uganda teaching that I was talking about. And definitely, there are some challenges with using television. The problem we have now at this moment is that for Singapore, at least, most of the nurses are foreign nurses. So sometimes language and communication is a problem, particularly when the elderly, most of them speak only the local dialects, and the foreign nurses can't. Of course, the other issues include the fact that because we are working with many different partners, so each partner have their own style of working, which may not be the same as the acute hospital. So, which is why there's a lot of communication that needs to be done. I'm just going to try and show you all how the telegeriatric system setup is like in Singapore. So I'm going to try and connect to them via Skype. Let's see whether it works, okay?
ยังไม่เสร็จเดี๋ยวเขาจะโชว์ให้ดูว่าถ้ามันมีเทเลเมดิซีนเนี่ยมันจะทำยังไงนะเขาอยากจะโชว์ให้ดูนะคะเดี๋ยวสรุปนิดหนึ่งว่าสิ่งที่เขาพูดเนี่ยเขาพูดถึงในฮอสพีซก็คือในเหมือนกับเป็นสถานที่ที่ดูแลนะเหมือนเนอร์ซิ่งโฮมแบบเนี้ยนะคะเหมือนเนอร์ซิ่งโฮมซึ่งมีกระจัดกระจายทั่วไปในแอเรียของเขาเนี่ยใช้เจอรี่แคร์แอดนอร์ทคือทำเฉพาะส่วนเหนือภาคเหนือของสิงคโปร์นะคะแล้วก็สิ่งที่เขาทำเนี่ยก็คือสิ่งที่เขาเน้นย้ำก็คือว่า1ต้องทำงานเป็นทีมนะ2เนี่ยต้องมี holistic care นะคะ อันหนึ่งนี่เขาบอกว่า caring of human ก็คือไม่ใช่คนไข้นะคือคนไข้เนี่ยเป็นคนหนึ่งให้ถือว่าคนไข้เนี่ยเป็นคนหนึ่งซึ่งจะมีอะไรต่ออะไรมากกว่าคำว่าคนไข้มากนักนะคะแล้วยังไงก็แล้วแต่เนี่ยสิ่งที่เขาบอกว่าเราจะทำให้คอสมันลดลงแล้วประสิทธิภาพเพิ่มขึ้นเนี่ยใช้เทเลเมดิซีนมาช่วยเนี่ยมันจะช่วยได้เยอะเมื่อกี้เขามี3ตารางเห็นไหมมีเปรียบเทียบว่าถ้าใช้เทเลเมดเนี่ยนะเวลาก็น้อยเงินก็จ่ายน้อยแต่ว่าถ้าใช้ใน hospital เนี่ยเวลามากขึ้นนะคะจ่ายมากขึ้นนะอันสุดท้ายเนี่ยเวลามากขึ้นแต่จ่ายน้อยลงนะอีกอันหนึ่งเวลามากขึ้นจ่ายมากขึ้นแต่จ่ายน้อยกว่าแต่เวลาน้อยกว่าไอ้ที่ไปอยู่ใน hospital นะคะก็สรุปก็คือว่าเขาคิดว่าควรจะมีเทเลเมดเนี่ยมาช่วยนะแล้วเดี๋ยวจะโชว์ว่าเทเลเมดเนี่ยทำยังไง so please you like to show you ready for that let's try เขาจะเทเลมาจากสิงคโปร์เลยนะเนี่ยอันนี้เทเลมาจากสิงคโปร์เลยโอเค
Hi Dr. Lawrence
Hey hi no Can you hear me
Yes I can hear you
Okay sorry this one can turn around wait no I turn the laptop I turn the laptop around
Okay Okay
ให้ไปทางด้านเลย
so this Can you see the audience? Wait for a while.
ได้ยินเสียงไหมคะให้เขาเอาเสียงโอเควันนี้เรามีข้อขัดข้องทางเทคนิคพอสมควรนะคะ
Hello.
Maybe you could use this microphone. That one
yes.
is not. It's working.
Hello.
Yes
Can you hear me?
Yes I can hear you
Okay, you can see the audience.
Yes
Say hi.
Hey Yes my son here
Yeah. You introduce our friends in Thailand, our tele-geriatric system in the hospital.
Okay sure So here is our tele-geriatric system we can actually see another side from our nursing home. At the same time, we can also see the staff in the KTPH side. Yeah. So if you look closely, this is our KTPH staff here, whereas there will be another staff in the nursing home side. So our system consists of the whole trolley with the camera system on the top. Yeah. Okay. So there will be a doctor sitting here and interacting with the nursing home side. Okay.
Thank you very much. No?
Welcome.
Okay, we can hang up now.
Okay.
Yeah, so that's it's similar. What you see on Skype is very similar to what we do, except that of course with that system, the computer, the resolution is way higher, and the sound definitely is better. So that's all I have for my tele-geriatric. Thank you very much.
So this session can conclude as we know about all of three speakers tell us about how to manage of palliative care, especially for cancer patients in Singapore. And so we have a big picture from the first speaker that is about the healthcare system in Singapore. And then how the palliative care is included in the big system. And the second speaker tell us about the palliative care in the setting, like in home peace and also hospice. And so the third one from Dr. Lauren Tan show us about the telemedicine, that we can use IT to help us work. Like he showed us about the telegeriatric nurse training course. They do this, the telemedicine, using it as the to have a telegeriatric nursing training course, so that it is a very good, it's a very good way to make it to less spend of money and also less time. So I just think about this is a very good experience from our neighboring country that is show us that this is the way that Singapore has experienced, and they think about the whole population. So they have a very good healthcare system to cover all of their population. So I just think about if you are happy with 3 of them, so please give them a big hand. So, any question? Any question? One question, please. So you can come up in the front. Yeah. You can use the microphone here. Introduce yourself first.
Dr. Sushira, I'm a psychiatrist of our hospital. My question in Thai first. ประเทศไทยกำลังจะเข้าสู่สังคมที่เป็นสังคมผู้สูงอายุนะคะเราจะเตรียมพร้อมอย่างไรมีคำแนะนำหรือไม่ Okay, now Thailand become an aging society. We will become an aging society soon. So, what we could prepare for this? Any opinions or recommendations?
So, Dr. Achilles, please.
ฝากคำถามหนูมีคำถามอะไรหนูถามเลยลูก
Thank you, Dr. Suchira, for the question. I didn't expect you to ask a question, but anyway, as we are all sitting here listening to me speak, and as I'm speaking, all of us are already aging. You believe that? Yeah? No. Okay. The fact is, unfortunately, we are aging as we speak. Okay? And the question was, how do we prepare for this aging population as a whole? I think it has to be a system which has to be in place. You cannot just do it as an individual or as one organization. So in Singapore, I think the health ministry saw this coming a few years ago, and they of course did the research. They looked into the statistics which are already there with the Ministry of Health. They looked at the number of patients, the trends that were happening with patients, and what is the aging trends in populations, where are the patients being taken care of, what is the family structures in place. So a whole lot of research, healthcare research, social research, everything had been done before actually the places were done. Let me just share with you a story which is what happened with me. You saw HCA Hospice Care where I was working as the CEO and medical director. The Health Minister for Health, Mr. Kobunwan, this is a few years ago, the Ministry of Health called me and said that he is interested in doing home visits, going and seeing patients in their own homes. I was taken a bit by surprise because I didn't expect the health minister to come out for home visits. But he did. So they asked me, can you plan 2 hospice patients at home so that he can visit them at home? So we chose patients who were able to speak and also the families who were willing to speak. We were told not to tell the patients that the minister is coming, so we had to keep it a bit of a secret. But I also told the ministry that these are hospice patients, and if I give you the names one month in advance, there is no guarantee that the patient will be alive when the minister actually visits home. And this happened. 2 weeks before the minister was supposed to visit, one patient passed away. And 1 day before the minister was supposed to visit, the second patient also passed away. So we fixed 2 other patients. But once he saw what we did at home, as we were going back to the office, he said, Akhilesh, this is what we should be doing. So he was very convinced when he spoke to the patients and the family that this is something we should do more and more. And I think the health ministry, once he made the decision that we should support more and more home hospice, I think more support came for us from the ministry. So sometimes these things have to happen. It can be one person who sees this, who has the vision and says, for an aging population, there is no point building more and more hospitals. We have to build hospitals so that they're supported, but we need to improve or strengthen the services in the community so that the patients can be kept and taken care of in their own homes, and so that they don't go and fill up beds in the ward when actually they can be taken care of at their own home. And the cost, healthcare cost, okay? So we look at the cost. If a patient was in a hospital, roughly right now, the cost would be about 450 Sing dollars per day. If the same patient was taken care of in an inpatient hospice, it will be about half that, maybe between $250 to $300 per day. If the same patient is taken care of at home, it will cost about $125 per day. How much? 125. 450, 250 to 300, 125. So you can see that there is cost efficiency and there is also cost effectiveness, because you are actually trying to support the patient at home, because that is where the patient wants to be. So Dr. Suchira, a long answer to your question, but the answer is that you have to have more than one particular organization or one doctor working for this. You have to have the entire system in place, starting from the hospitals, maybe community hospitals, maybe nursing homes, and develop more and more community services. So you in your own hospital, your palliative care unit has to be well formed so that you start looking after. And believe me, you're not just going to be looking after only cancer patients. You will look after non-cancer patients also. End-stage renal failure, end-stage heart failures, COPD patients, neurological disease, motor neuron disease. So many different patients. As long as you are able to develop those services, I think you will have success of looking after an aging population and giving them the quality of life that they deserve. I think this is important, that you have to be able to do justice to those patients, give them the dignity and the quality of life that they deserve during the end of life. Okay, thank you.
Thank you. So Dr. Suchira, you'd like to explain the translation for...
Can you translate for it? Or we have a translator?
หนูจะแปลให้คนที่อยู่ในห้องประชุมเขาฟังไหมว่าเขาพูดว่าอะไรเมื่อกี้เนี่ยเชิญค่ะ
ค่ะสำหรับคำตอบของคำถามเมื่อกี้นะคะก็คือเขาบอกว่าเราไม่สามารถที่จะเข้าสู่สังคมผู้สูงอายุได้หากเราเปลี่ยนแปลงแค่ ที่ตัวเราหรือแค่เพียงองค์กรใดองค์กรหนึ่งค่ะเราต้องดำเนินการด้วยความร่วมมือขององค์กรต่างๆร่วมกันและเปลี่ยนแปลงที่ตัวระบบอาจจะเป็นจุดเริ่มต้นมาจากแค่ที่โรงพยาบาลก่อนก็ได้ค่ะโดยทำให้ผู้ป่วยเนี่ยตระหนักถึงความสำคัญของการดูแลแบบpalliative ค่ะโดยก็คือเปรียบเทียบให้เขาเห็นว่าราคาของการรักษาในสถานที่ที่ไม่ใช่โรงพยาบาลเนี่ยมันถูกกว่ากันกว่าครึ่งหนึ่งค่ะแล้วก็ผู้ป่วยเนี่ยก็จะมีคุณภาพชีวิตที่ดีขึ้นในอนาคตด้วยค่ะขอบคุณค่ะ
สรุปว่าอย่างนี้สรุปว่าควรจะเน้นการดูแลที่บ้านก่อนนะควรจะเน้นคือที่เขาเน้นเนี่ยก็คือว่ามันจะต้องดูแลที่บ้านพยายามที่จะเทรนคนหรือพยายามที่จะสร้างระบบพยายามที่จะมีอะไรปัจจัยเอื้อทั้งหลายแหล่เนี่ยต้องเริ่มที่บ้านก่อนเพราะเริ่มที่บ้านเนี่ยมันถูกกว่าเพื่อนมันคอสมันถูกกว่าเพื่อนนะคะอันนี้คอสมันถูกกว่าเพื่อนไม่ว่าจะเป็นขยับขึ้นมาเนี่ยมันก็แพงขึ้นนะคะอันนี้ก็คือว่าถ้าเราจะดูแลคนสูงอายุในอนาคตเนี่ยนะเราต้องดูแลที่บ้านนะคะก็สรุปว่าอย่างนั้นนะโอเคต้องขอบคุณน้องชื่ออะไรคะ
ปิงปอง
ชื่ออะไรนะ
ปิงปองค่ะ
ปิงปองน้องปิงปองจะปรบมือให้น้องปิงปองด้วยนะคะ
เดี๋ยวจะอยู่แปลกับเราอีกค่ะอาจารย์
So I think maybe now we run out of time because now it's 3:30. So I just would like to thanks again for the three speakers. That is very wonderful presentation. Thanks again. Yeah. So we will move to the next presentation. The next symposium. This is from Professor Michael Zimmerman from Iodine Global Network. So please come up to the stage. Please welcome him. Today, Professor Zimmerman will present us about the iodine deficiency disorder in the topic of elimination of iodine deficiency, the global challenge. Yeah, and he will touch upon a little bit upon the relation of thyroid cancer. So please.
All right. First of all, good afternoon, everyone, and it's a great pleasure to be here, of course, to talk to you about iodine deficiency. I think this topic is actually very relevant for this conference because, as many of you may know, this part of Thailand in the old days was the goiter belt of Thailand that had the highest amount of iodine deficiency disorders. And there is a clear connection between correcting iodine status in populations and the prevalence of the more aggressive forms of thyroid cancer. So I'd like to first thank Dr.Sangsom Sinawat for the opportunity to present some of this to you today. And we'll start by looking at a picture. This is a picture of where I come from the old town of Zurich. So I'm from the University of Zurich in Switzerland, which is the Swiss Federal Institute of Technology. Now I'd like to start with a question for you. If you had $75 billion to spend on global development, where would you start? Now this was a question that was posed twice to a group of Nobel Prize winning economists in Copenhagen. And both times they came up with the same answer. So I want you to take a guess as to what they replied to this question. They were asked, which is the best global development investment? Did they say education, armed conflict, ending climate change, addressing chronic diseases, addressing infectious diseases, addressing water and sanitation issues, addressing population growth? No, they didn't say any of these answers. Actually, what they said was the number one best investment in development for most countries is correcting micronutrient malnutrition. So when we talk about correcting micronutrient malnutrition, we're talking mainly about iron deficiency, iodine deficiency, and vitamin A deficiency around the world. The reason that it's so effective to spend money on correcting micronutrient malnutrition is because it leads to so many benefits in a population. It leads to improved child growth, to better learning at school, healthier pregnancies, increased work productivity overall, and increases in countries' GNP. It's estimated that about a $1 investment in correcting micronutrient deficiencies leads to a payoff of approximately $35 for countries. Now, iodine deficiency is one of the micronutrient deficiencies that was specifically pointed out as being a great investment for countries to correct this, because the intervention we have for correcting iodine deficiency is so inexpensive and so effective, and that is using iodized salt. So iodine deficiency disorders for many years were one of the most common human diseases around the world. And for many years, it was the most common cause of preventable mental retardation in populations. And we have a very simple and inexpensive intervention that can correct iodine deficiency, and that is salt iodization. So I'll talk about first the effects of iodine deficiency, and particularly the link between iodine intake and thyroid cancer, and then talk about how we define iodine status, talk about the global prevalence of iodine deficiency, and finish with some words about how we can sustain the elimination of iodine deficiency. So I'd like to go through the life cycle quickly and just briefly talk about the benefits of correcting iodine deficiency through the life cycle. First, if we provide adequate iodine to women during pregnancy, we avoid all the damage that occurs in utero to the developing brain from iodine deficiency. If a pregnant woman does not have enough iodine, the fetus will become hypothyroid, and this leads to irreversible brain damage. So this can cause cretinism in its worst form, but also it's been shown in well-controlled intervention trials that increasing iodine intakes in deficient pregnant women lead to IQ point increases of 10 to 12 points. If we move now to infancy, this is a famous study done by Johns Hopkins in Indonesia that showed sharply reduced rates of infant mortality in an area of severe iodine deficiency when infants were repleted with iodine. So there's decreases in infant mortality in areas of iodine deficiency. If we move now to childhood, if you correct mild to moderate iodine deficiency in children, you can increase their cognition and fine motor skills. And there's two very nice randomized controlled trials, one done in Europe, one done in New Zealand, both of which showed benefit of correcting even mild iodine deficiency in children with IQ point increases between 2 and 5 points. If we move to adults now, as you know, one of the main effects of iodine deficiency is goiter, and often if goiter is long-standing, individuals will develop multinodular goiter. Now, one of the main effects of iodine deficiency in Europe is that adult populations have much higher prevalences of hyperthyroidism because there are much more incidents of multinodular toxic goiter due to nodules that develop in iodine-deficient thyroids. So one way we can reduce the amount of hyperthyroidism in populations is to reduce goiter by providing adequate iodine to populations. The figure on the right side of the slide shows you that in Denmark, in areas of more severe iodine deficiency, there are much higher rates of hyperthyroidism, especially in older women. Also, if we correct iodine deficiency in adults, we can actually reduce cholesterol. It turns out that any condition which causes hypothyroidism will increase blood cholesterol and increase risk for cardiovascular disease. And when we improve thyroid function by delivering iodine to populations, we can lower cholesterol and thereby a population's risk for heart disease. So that's another major benefit of correcting iodine deficiency in adults. Now, what about the link between iodine intake and thyroid cancer? We recently reviewed this topic, so if you're interested to know more about this possible link, you can look at this paper which was published last year. Essentially, we looked at animal and human studies that link iodine intake to thyroid cancer. Around the world, in many countries, there's been a sharp increase in the incidence of papillary thyroid cancer. And there's been a question about could this increase be potentially linked to increases in iodine intake due to iodized salt programs. Now, most experts feel that this increase in thyroid cancer is due to increased diagnostic intensity in populations. There's much more ultrasound available to detect very small carcinomas in the thyroid. But there remains this question about, is there a link between iodine intake and thyroid cancer? If you look at animal studies, predictably, if you make rodents iodine deficient, they develop hyperplasia, they develop nodular goiter, and eventually in a small percentage of animals, they will develop follicular adenocarcinomas, especially female animals. This figure shows you that thyroid tumors develop in animals at very low iodine intakes and also at very high iodine intakes. And also, it looks like iodine deficiency or iodine excess is a strong promoter of thyroid cancer if an initiator is present, for example, like a chemical carcinogen or radiation. So in animal models, iodine deficiency clearly increases risk for thyroid tumors, and so does possibly very much iodine excess. Now in human studies, if you look at populations and you look at if a population and individuals in the population have a history of goiter due to iodine deficiency, this increases risk for thyroid cancer sharply. The odds ratio in 12 case control studies that were pooled was about 5.9 for women who had a history of goiter and 38 for men with a history of goiter. So we know that iodine deficiency is a major risk factor for goiter, and goiter is a major risk factor for thyroid cancer. Now, although it's rare, most thyroid cancer mortality is due to the most aggressive form of thyroid cancer, which is anaplastic thyroid cancer. And it's been shown repeatedly that in areas of iodine deficiency, rates of anaplastic thyroid cancer are much higher. And if you can correct iodine deficiency by introducing iodized salt into a population, you reduce the risk of anaplastic cancer very sharply. And this has been shown in Argentina, in Austria, in Germany, and the country where I come from, Switzerland. As you can see in this table that shows you the reduction in the percentage of thyroid cancers that are anaplastic after the introduction of iodized salt. So this is a major benefit of introducing iodized salt to populations, is you have less of this very dangerous form of thyroid cancer, anaplastic thyroid cancer. Now, there's been many studies which have looked at the shift in thyroid cancer when iodine intakes are increased in populations, and it does look like there is a ratio shift from the more aggressive forms of thyroid cancer, that is anaplastic and follicular forms, to papillary forms, which are more easy to treat. Let's skip this one. If you look at the USA over the last 30 years, if you look at the red line in this figure, between 1970 and 2010, you can see there's been a very big increase in papillary carcinoma among women. And you can see there's been very little increase in follicular carcinoma at the same time. But what's interesting is during this period where there's been this about a 5-fold increase in incidence of thyroid cancer, you can see in the top line the median urinary iodine concentration. This is the iodine intake in the US population. You can see how much it's fallen from close to 300 microgram per liter in the 1970s down to, in 2010, only 138 micrograms per liter. So the US is a very good example of a country where there's been a large decrease in iodine intake, but a large increase in the incidence of papillary thyroid cancer over the last 40 years. Now, we did a review of this to look at the change in thyroid cancer mortality in women versus the change in the median urinary iodine concentration between 2000 and 2010. And you can see from this plot that there's an inverse relationship between an increase in the incidence of thyroid cancer mortality in countries and an increase in iodine intake from iodized salt. So this also suggests that increasing iodine intake through iodized salt may be protective. We did a meta-analysis of the available case control studies that looked at iodine intake from the diet and thyroid cancer. And you can see this is the overall forest plot showing the risk of thyroid cancer by differing iodine intake. And you can see that with increasing iodine intakes, there was about a 23% reduction in risk of thyroid cancer in populations. So that's an overview basically of the animal and human data that suggests that if we correct iodine deficiency in populations, we can decrease particularly the amounts of the dangerous form of thyroid cancer, that is anaplastic thyroid cancer. So I think it's one of the other benefits of the very effective iodine program, which is present in Thailand, is that it's probably decreasing the amount overall of the more dangerous forms of thyroid cancer in the population. The other link between iodine and thyroid cancer is after exposure to radioiodine nucleotides, after, for example, a nuclear accident, it's been shown that in iodine deficient populations, if there is exposure to radioiodine during fallout, the prevalence of thyroid cancer is much higher. Because in iodine deficient populations, like these children, after the Chernobyl accident in Central Europe in 1986, the populations that were iodine deficient, because their iodine deficient thyroid took up so much more iodine from the environment, had much higher rates of thyroid cancer. So this is another way that ensuring adequate iodine status in populations reduces the risk of thyroid cancer after exposure, for example, from a nuclear fallout or a nuclear accident. Okay, so if we look at all of these effects of correcting iodine deficiency in populations, this is a cost-effectiveness summary. It's been estimated that the annual potential costs that were attributed to iodine deficiency disorders in the developing world prior to widespread salt iodization were about 36 billion. We've spent about 0.5 billion on salt iodization. This yields a 70-to-1 benefit to cost ratio. And it's been emphasized, for example, in the quote in the lower part of the slide by the International Child Development Steering Group in the Lancet, that salt iodization remains the most cost-effective way to deliver iodine and improve cognition in children. So with that, I'd like to move to the second part of my talk, which is how do we measure iodine deficiency, and are we making progress around the world against iodine deficiency? Now, as most of you know who work on iodine, we measure iodine status in populations with a very simple biomarker, and that is the iodine concentration in the urine. So we collect urine samples from the population we're interested in, and we look at the iodine concentration, and we can then get a good feeling of recent iodine intake in populations. It's a very sensitive indicator of iodine intake over the previous 48 to 72 hours, because about 90% of the iodine that we take in will excrete during that period. So it reflects recent iodine intake, and it's a very good population indicator. It's not such a good individual indicator because day-to-day variation is very high, but if you get large numbers of samples in a representative survey, you can get a feeling for population iodine status. So this is the measure that WHO recommends for assessing iodine nutrition in populations. And this simple table shows you how WHO categorizes iodine status in populations based on the median urinary iodine concentration. So for example, what we're aiming for with an iodized salt program is to achieve a median urinary iodine concentration of between 100 and 199 micrograms per liter in children, for example. Deficiency is a urinary iodine concentration below 100 micrograms per liter, and excessive iodine intake is when the median goes over 300 micrograms per liter. So, we can use this as a sensitive indicator of recent iodine intake. I'll skip this part here and move to the recent progress against iodine deficiency. Now, we're really fortunate in the iodine field because we have very extensive coverage of urinary iodine concentrations in nearly all countries around the world. It's estimated that urinary iodine concentration data cover about 97% of the global population, which is really remarkable coverage. When we talk about many other indicators of nutrition status, for example, anemia rates or vitamin A deficiency rates, much of that data is extrapolated data because there isn't that much coverage in terms of surveys, but urinary iodine concentration data cover about 97% of the global population. And if you look at the data in 2012, which is the bar on the far right, you can see we actually have national surveys in almost 120 countries around the world, recent national surveys, and in 32 we have large subnational surveys. So the quality of the data that has been used to generate the estimates over the next few slides I'll show you is actually very high and directly measured. So there's only 42 countries left in the world that don't have any data on iodine status in their populations, but these are mostly small countries, and only about 3% of the global population, we still don't know what their iodine status is. But if we look at the rest of the world, global progress against iodine deficiency since about the early 1990s has really been remarkable. It's been described as a major public health triumph by UNICEF, for example. So if we look at the world map in 1993, you can see that all of the countries that are purple colored in this map have various degrees of iodine deficiency. The more intense purple, the more severe the iodine deficiency. So most of Asia, including Thailand, Africa, and South America, was affected by iodine deficiency. Now, if we move from 1993 to 2003, here's the global map. Look how much progress was achieved in a decade from 1993 to 2003. You can see that most countries in Latin America, for example, had eliminated iodine deficiency in school children. Many countries in Africa and big countries like China and India in Asia had also increased iodine intakes enough to eliminate iodine deficiency disorders in their population. You can also see that Thailand, during this period from 1993 to 2003, because of a very effective iodized salt program championed by Dr. Sinawatana, was effective in terms of increasing iodine intake so that school children in Thailand were iodine sufficient in 2003. If we look at over the next decade from 2007, you can see there's further progress. Fewer and fewer countries have a purple color. You can see that many countries in Africa now are becoming iodine sufficient through iodized salt. And finally, the final map is from 2013, and you can see that there's only 31 countries around the world that remain iodine deficient. So there's been really remarkable progress around the world in covering populations with just the right amount of iodine through iodized salt. The number of countries has fallen dramatically. You can see from 110 countries that were deficient on the national level in 1990 to only 31 deficient in 2011. If you look at a bubble graph, this shows you that there were 113 countries that were iodine deficient in 1993. So you can see that the goiter rate is very high on the y-axis and the iodine intakes are very low on the x-axis. And if we look at the change between 1993 and 2015, look how all the bubbles have shifted into higher iodine intakes and almost no goiter left in the populations. So it's a really dramatic visual representation of the progress in correcting goiter in populations through increasing iodine intakes with iodized salt. Now, this is the latest UNICEF map, which shows you the progress toward universal salt iodization in countries. You can see that most of the countries that have a light blue or dark blue, a light blue or a very light purple color have at least 50% of their populations covered by adequately iodized salt. We still have a ways to go in many countries to improve coverage, but this is why we've managed to eliminate iodine deficiency in most countries, is we have fairly good coverage of iodine, of households with iodized salt. Now, I must emphasize, although we've made remarkable progress, we still have to be careful because UNICEF estimates that each day there's about 120,000 babies which are born iodine deficient and at risk for mental and physical retardation. You can see that most of these babies are in South Asia and Sub-Saharan Africa. So we have to be very careful. We need to continue to push for even wider coverage of iodized salt, particularly in South Asia and Sub-Saharan Africa, in order to ensure that every baby is born able to reach its full mental and physical development because it's had adequate iodine in utero. Now, I'd also like to emphasize that that iodine deficiency is not only a problem in developing countries or in low and middle income countries, it's also a problem in many high income countries. This shows you of all WHO regions, Europe actually, the European WHO region has one of the highest prevalences of mild iodine deficiency. You can see in the bottom right figure that UK schoolgirls, for example, are iodine deficient. And on the right side, you can see that in around 2004, Australia was also suddenly discovered to be iodine deficient with increasing goiter rates in school children. So iodine deficiency, unlike, for example, vitamin A deficiency and other micronutrient deficiencies, can also affect high-income countries. In fact, in the United States, pregnant women are now mildly iodine deficient. And you can see these are the data from the national health surveys that are done in the US every year. And you can see that the median in pregnant women is only 129 micrograms per liter, and it should be above 150 micrograms per liter. The reason that many high-income countries remain mildly iodine deficient is because although there may be iodized salt available for household use, most salt intakes come from processed foods. For example, in North America and Western Europe, it's estimated that probably 80 to 90% of our salt intakes come from processed foods and not salt that's added at the table or during household cooking. And the problem is many processed foods in these countries don't use iodized salt. So that's why, for example, much of the population of Western Europe has very mild iodine deficiency, and pregnant women have low iodine intakes in the United States. So it's not just a problem in low-income countries, it's also a problem in high-income countries. Now, I'd like to finish my presentation just talking about sustainability. You can see that we've really made remarkable progress around the world, and we have adequate iodine intakes in many countries now due to iodized salt. And I think this also applies to Thailand. We have very good coverage of most of the country with iodized salt and iodized fish sauce. There still remain pockets of iodine deficiency. There still remain areas where pregnant women have low iodine intakes. But the key now is to sustain the progress in most countries around the world. And the Ministry of Public Health in Thailand has a new initiative, which I think is a very good one in terms of trying to maintain and sustain the success of the iodized salt program in Thailand. So if we look at sustainability, the first thing is that salt has to be available, right? There has to be enough iodized salt, well iodized salt, produced by the salt industry to cover the population. The second thing is that this iodized salt has to be accessible to the population. So distribution and coverage of even remote poor areas with adequately iodized salt has to be improved. And finally, it has to be affordable so that people can afford it, and there has to be consumer demand so that people know to buy iodized salt when they see it. So for example, in Thailand, in a new initiative, which is being piloted actually in provinces of northeast Thailand by Dr. Sinawat and her colleagues at the at the Ministry for Public Health in Thailand, is looking at first ensuring that the Ministry of Industry needs to support the iodized salt producers so they can produce adequately iodized salt in amounts that will cover the population. The second thing is the Ministry of Commerce needs to support the distribution of iodized salt to all the population. And finally, the Ministry of Public Health needs to continue to inform the population on the health benefits of correcting iodine deficiency so that there's consumer demand for iodized salt. So you can see that when we want to sustain the achievements in terms of iodized salt, it takes multiple sectors: the Ministry of Industry, the Ministry of Commerce, and of course the Ministry of Public Health. So with that, I'd like to conclude just by emphasizing my key points, and that is that iodine deficiency causes adverse health effects throughout the entire life cycle, from pregnancy through old age. There's been major global progress against iodine deficiency across the world over the last 2 or 3 decades, including Southeast Asia and Thailand. But these achievements are fragile and they need to be sustained. And sustainability is really the key now in most countries around the world, including Thailand, and this needs to be achieved by contributions from all sectors of society. So with that, I'd like to thank you very much for your attention.
So thanks very much, Professor. Sorry, at the first I forgot to introduce him. Actually, he is a professor of at the University of Zurich, Switzerland, and he is the head of Human Nutrition Laboratory, Institute of Food, Nutrition and Health, Department of Health Science and Technology, Zurich, Switzerland. And the most important role, I think, for him is the chairman of Iodine Global Network. Actually, he is my big boss because I have been appointed by him to be a national coordinator of Thailand. So I think it's very great honor of the Thai population, you know, because he has visited us maybe every 1 year annually. Yeah, because maybe he worried about our program, you know, and every time we have got very useful